The talk today is going to be kind of in general terms on how to read a psychological eval, what goes into it. I've got a sample on the screen that I thought might be an okay example of the different sections in the report, what you might look for in each section, what some of the numbers mean, and as we work our way down then to the bottom of the report, look at diagnosing and recommendations piece. It just occurred to me, for some folks who have been looking at these kind of reports for a while, this talk might be a bit elementary. But we can turn it into not elementary with some seasoned person questions if you have them. So what I would have all of you do though is as I'm talking, as I'm going through it, if a question pops up, just let's get that done, because those will make it a bit more meaningful for everybody rather than hearing me talk for 30 minutes, which it may or may not take. Let's see. So well, first off, before I even start, are there any questions? Anybody have any item that they get a report and they always wonder, what's this about, why is this here? Anything instantly come to mind in that regard? Yeah.
Rule out. I understand it means it needs to be ruled out, but how do you go through the process of getting ruled out? Is it age? Is it you need to have more assessments done?
Okay. I should say, hold that till I get to the end. Don't.
You said it.
Well, so everybody can hear. Everybody remember for her. That's an important one because it's not an obvious. I think most people see that and they think, oh, it's been ruled out. I mean, that's the lay person. So they take that off the table when it's actually the reverse that should be the case. So hold that. Any others that we should hold? Okay. The report always starts out with, why is the child being referred? We could say it's DFPS policy, it's CK policy, but in terms of why you're doing an examination of a child, that's really, as far as Medicaid is concerned, that's not sufficient. There needs to be a referral source. What are some issues? What are some concerns that the evaluation needs to attend to? So any questions or concerns that come up in the referral information need to be addressed at the end of the report. Okay? And I could confess, I'm not sure how often I really go back and attend to that, but that's a pretty important piece. If someone is wondering about attachment disorder, on the referral form that you fill out, I need to attend to that at the end of the report. That's pretty basic. Just to reiterate, this is where I would put information that you would put on that referral form. Why is the child being referred? That's where that would go. In that part of when I'm sitting with the foster parent, this is where I also try to get from them what their chief concerns, if any, are about the child. So I've got the case manager's input, and I've got then the foster parent input on what I need to be looking for. What the concerns are then drive what tests I use. The other driver of what tests to use is the child's age. So this child was 3. That's, I think technically way back when we defined kind of arbitrarily here, age 3 and up is a psychological and below 3 is a developmental. That's a little arbitrary, and I kind of tweak that when I see the child and I see what the needs are. But as far as what you click on the drop-down menu, it's not a problem just to adhere to that under age 3 thing. Developmental measures are always the case with little ones. The child behavior checklist is a form that I use. Gosh, I bet since I started doing this in 2005, I bet we've done a few thousand of those. That's pretty much the standard on every child, regardless of age. There's just a different variation in the form based on their age. With a 3-year-old, we could do an IQ test. If there's a concern about intellectual disability, if the child may have Down syndrome when they've never had an eval before, if there's some prenatal drug exposure or prematurity, we can do an IQ test technically down to age 2. But I think the utility of an IQ test on a child that young is pretty limited, unless there's some purpose in terms of treatment services, some sort of planning that needs to be done. I generally don't do that until age 3.5, maybe and up. I always include where I saw the child. I like to note how long they've been in the home. How long the child's been in the home gives me information as far as are they still adjusting? Have they been in the home 3 years? If they've been in the home 3 years and as we go through the report there's still a ton of acting out, that's good data to suggest it's not simply an adjustment reaction. So that's important for my knowledge. Basis for placement, I get that from foster parent, I get it from you guys, I get it from Access. The perfect document for me to have to fill out that area is the affidavit. We probably have that on file 50% of the time, give or take. When I have it, it's wonderful in terms of information, of accurate data. When I don't have it, we just make do. The family history section, for our kids, that's usually a really brief snapshot because there's not a wealth of information. If there's an affidavit, there is a wealth. What I've learned over the years, the more detailed I try to make this section, the more I set myself up for having an incorrect piece of data, a typo. I transpose a number. So there's a real balance for me as I'm writing data and detail versus generality. There's some people in this room who are very quick to point out my errors, which is usually fine. Sometimes it's not helpful. Sometimes it's very helpful. But if there's going to be errors, it's usually here. Developmental medical history, should stand for itself. In the case of this child, it was particularly relevant because he was quite preemie, which then plays into everything else that follows. We generally don't know if kids are prenatally exposed to drugs, but in this case, that's something that the foster parent asserted. Okay. It's important to note if the child has any history of participation in any sort of habilitation or rehabilitation services. Again, that gives me a context. If I see them functioning at this level, to know that they've already been in those services for the past year gives great information in terms of their progress or lack thereof, or maybe even their prognosis. If they've been in services for 2 or 3 years and they're still functioning, at a very, very low level, then that's very valuable information. That probably lends itself to a treatment services issue, an IQ issue, certainly ongoing receipt of those services is an issue also. Okay, questions yet? Okay. The behavior observations with a small child. This is generally this is my observation of the child while they're here. If it's an older child, my conversation, my questions with the child all go in this particular section as well. foster parent, case manager is speaking about some issue with the child, if I see it myself, then that's good information. Oftentimes they'll portray a child and I don't see it at all, and that's because I think the novelty of the evaluation. You know, you've got a sick child, you go to the doctor and the child's fine. Everybody with children has experienced that, and that coming up and seeing me is really no different. The bouncing off the wall hyperactive child can sit with me for an hour and have near perfect focus, and they can appear angelic, sweet, etc. And this is not a specialized child. This is a basic child. Yeah, but I've done it long enough to know that perfection in behavior in front of me really is not diagnostic, especially if other people are portraying the child in a different way. Okay. The big developmental measure that I always use, actually two, the Vineland and the Beery VMI. This is kind of like the gold standard in child developmental assessment measures. It's always used, not always, vast majority of clinicians would use this measure in doing a developmental assessment, in doing a rule out for a disability, intellectual disability, which is the new term for mental retardation. And just a quick explanation of the numbers. Standard scores, you'll see me refer to standard scores on this instrument, on the Beery, there's 81. Standard scores are on IQ tests, like an IQ number that I would cite. That's also called a standard score. Generally speaking, the smack dab in the middle mean or average of a standard score is 100. So to give you some idea, this child, if smack dab average is 100, this child's 83, which is at the 13th percentile for a child his age, which is low. This is a composite score of all of these. The communication daily living at the 10th and the 13th. This is a child, because of those numbers, that I would refer for services, speech therapy services, potentially OT services. Any number that's 20th percentile or below is kind of my cutoff for making those referrals. An ECI cutoff, I don't know what the cutoff is, but it's always above mine. Where I say 20, I don't know, they might say 30th percentile. So it's typical for a foster parent to say, yeah, the ECI came, evaluated the child, and said they didn't need services. I see the child, and I see them below the 20th, and I say, well, I think they do. And generally speaking, I think all of our providers probably end up seeing the kid. ECI might not, but another service provider would. The VMI, it's a measure of visual motor integration. Some of you may have even seen me use that one. It's literally super short. It's just a quickie screener. The child is looking at a form and they're copying the drawings. The drawings get progressively more difficult. The first drawing is for them to simply copy what I do. A few items ahead, there's a simple line, a vertical drawing, then a horizontal drawing, and then a circle drawing. How far they go as those get progressively more difficult, then is a function of their score. This child did pretty poorly, which is at the 10th percentile. This is the measure that I always use to refer kids for occupational therapy. A VMI score, a percentile score, below the 20th percentile, I'd say they need to be assessed. My assessment using this instrument, I don't think has ever been sufficient to get OT approved. I believe these days that is solely the MD pediatrician person who can do that. I always start off this section of the report with the CBCL, that form I referenced at the top, Child Behavior Checklist. It's a blue form. Laura keeps copies of them for me up front. This form is one of the most important sources of information that I get from kids, which also happens to be subject to the most unreliability from a foster parent. Foster parents who want to chart up their kids do it here. Foster parents who downplay what's going on with their child do it here. My task is I give them all instructions on how to fill out the form, how to only answer based on what they see. They're circling, not true statements, a little true and very true. If they want the child to look bad, they just circle twos. Thankfully, I don't think we have a whole lot of that. I think those folks kind of get weeded out. Though there is then it's usually an adoptive mom. She's finally got her precious child she's been waiting forever to get. So I hand her the form, and all she wants to portray is angel child, when I'm hearing from you guys or Access that this is not angel child in terms of behavior. So I'll get those forms back, and they're all zeros, which pretty much says normal child, no behavior problems, which is bad information and not helpful. So I coach them all a little bit on how to fill out the form, and then just hope they do it as accurately as they can. Then we get into the summary. By force of habit, you generally have 3 paragraphs in the summary. There's an intro paragraph that gives information about the child, why they're here, why I'm seeing them, maybe a quick blurb about the family. The second paragraph is usually a quick picture of what my findings were. And then the last paragraph of the summary is kind of a formulation, kind of a summary, a blending of the data and why they're here into why I think they are what they are diagnostically. So by now, surely everyone is familiar with this as opposed to the 5 axes. Why are you grinning so big?
I didn't know you changed it. We were waiting on you to change it to change Access, and now we can change Access.
Oh, this has been like on every report coming in for a while.
I don't really have Access.
Okay, this is it.
I mean, I have Access, I just don't.
1, 2, 3, and 4. 1, 2, 3, 4, 5 gone.
You didn't change it.
It's just that is literally it. I don't like it. I mean, as a clinician, I could look at all 5 axes or get someone else's report that they had done, and that's where I go to get a real quick picture of diagnoses, of abuse history, of any medical issues, psychosocial issues, and then the GAF. Overall, how are they doing? Well, all that's gone. Don't really understand why we lost all of it, but we did.
Well, and some providers, they don't even list it out like that. It's in a paragraph form, so you really have to read through to find the diagnosis.
Yeah.
So, in what's in place of the GAF?
Nothing.
There is a correct now.
All you would get now would be what impressions you might form from reading the report. And, the GAF was never a really good number, but you got 10 clinicians, you get 10 GAF numbers. But generally speaking, they're not going to be terribly far apart, So, let's see, what do I need to say about that? Some of the developmental disorders require a lot more description than saying autism spectrum disorder. There's qualifiers that need to go, so that would give a bit more data, that the all 5 axes might have done in the past. But for the most part, you get the number and then the title, and that's pretty much it. Recommendation section, yes. Question?
Nancy, I have a question.
Go ahead.
Real quick about the diagnostic impression kit, but on one of my kiddos, and we did not autism spectrum disorder requiring substantial support provisional.
Yeah, that's one of those qualifiers. So you've got a child who I believe to be on the autism spectrum, which could be anything from Asperger's, what we call high functioning, all the way down to mute, no communication, rocking in the corner, autistic child. Then we have those qualifiers requiring substantial support, meaning he's not going to do much on his own. He's going to require supports around him. He's going to require rehabilitation. He's going to require 24-hour care, potentially. How old was that child?
Nicholas is 5.
Okay. Prognostically, that's not real good. If indeed that provisional label goes away, and it's that is the thing. Provisional means I think this is where he is, and I'm kind of hedging my bet, and I'm giving myself an opportunity to not be wrong. So I put provisional.
Is that just to see if he does better in a different environment?
Yeah. He's in a new environment, or he comes back and sees me the next year, and I kind of have a pre and a post now assessment of that child. And if there's been some good progress, he's still maybe doing poorly, but there's been great progress, then that qualifier might go away. The diagnosis might not, but the qualifier probably would. Rule outs. Rule out means I wonder. This child was, yeah. No, this is the technical term. Yeah. Prenatal drug exposure, born at 28 weeks. Surely there's something neurological with this child. There has to be. That's not my realm, though that's in an area of science it's just gray anyway, right? Gray matter. There's a pun there, I think. So we're not going to know, but there are some issues related to this that are present, and I'm just putting it out there to say, hey, FYI, there's other stuff going on. Not sure exactly what it is. It could be ruled out depression. Maybe there's 2 or 3 criteria that are present for a child, and they need 6 criteria in a given category. So I either didn't ask those questions in the interview, or those features simply aren't present, or were denied. But there's enough depression going on that I don't think we should overlook it. So then I list it as a rule out. This is to be attended to with the next eval, or if I'm referring to another provider, this is for you. Yeah. You might see a rule out for mixed receptive expressive language disorder. That's for the speech therapist to say, hey, this is yours to attend to. I'm not gonna.
So with the rule out of the neurodevelopmental disorder, would you then put in your recommendations if you wanted them to see a neuropsych? Just us reading that, would it mean that needs to happen, or if they need to see a neurologist, or they need to?
Potentially. Speech therapy. That could be in the future. But at this age, I really don't know what's going to come of it. If you could do that eval after some gains, maybe, so that there's more data that they can actually go after. Yeah.
Is there any age limit for the neuropsychs?
No. Oh, I mean a lower limit. I would have to say, yeah. There's an instrument called the Bailey Scales of Infant Development. That would be considered a early child neuropsych instrument, and that can probably be given to probably under 12 months. Yeah.
You would only want to do that if there was some severe,
Obvious need.
right?
Yeah.
So it's better to kind of watch rather than refer out.
You know, watching is fine up until 3, 4. If there's still issues there, you really do need to kind of nail things down. We want to diagnose autism these days before age 4. I think some people would say by age 2 you would like to get that one nailed down, just so that services can be started. Question? Oh. Any others?
Do you have a minimum time frame before you assess the kids when they're placed in the home? Do you wait a certain period of time?
Well, by nature of what we do and the need to do things, within 45 days sometimes, that often might dictate when they're seen. Ideally, you got a child who's been removed and they're put into a new home. For many of our kids, then we come in and do an assessment, and what the assessment says is this is how the child looks in the middle of trauma and crisis. That might be a little bit helpful, but it has nothing to do with how they'll do once things have settled down a little bit. Some of those kids don't settle down, and they just stay up. That eval then is a bit more reasonable, but generally speaking, the earlier they're seen, the less accurate the picture might be because of that adjustment piece. Yeah. Okay, we're done.